Hi, this is Solomon Culver, and I'm a hospitalist at The Ohio State University. This is the third lecture in a series leading up to an analysis of the paper Restrictive or Liberal Transfusion Strategy in Myocardial Infarction by JL Carson. The name of this lecture is Mice, Missing Data, and Acute MI. And before we get started, please like and subscribe to help my channel reach more viewers. Clinical trials are designed to measure an association between a treatment and an outcome. But when a trial design or when the implementation of a trial causes distortion of those associations, making them seem bigger or smaller than they actually are, then we call that a bias. And one major source of bias in clinical research is called selection bias. This is when the selection criteria of patients into the trial is somehow linked to both treatment and outcome. In a randomized controlled trial, selection bias is essentially caused by what we call outcome-dependent differential loss to follow-up. A loss to follow-up is outcome-dependent if it's more likely to affect patients based on their outcomes. For instance, if a patient who is sick is more likely to drop out of a trial than a patient who is healthy, then we would call that outcome-dependent loss. A loss to follow-up is differential if it affects more patients in one treatment group than the other. And because we can only analyze patients in a clinical trial who don't drop out, then when a trial has both outcome-dependent and differential loss to follow-up, this means that we're only analyzing patients in a pattern that's based on both their treatment and their outcome. Therefore, it causes selection bias. So how do we recognize selection bias in a clinical trial? Selection bias essentially occurs only when there is both differential loss and outcome-dependent loss to follow-up. But since we can never really know what the outcomes would have been for patients who are lost to follow-up, we can really only identify the possibility of selection bias by noticing when there is differential loss. And for that reason, every clinical trial comes with a consort flow sheet, which is a figure that details the exclusions and the missing data patterns at each stage of the trial implementation. So how do we interpret differential loss to follow-up? Essentially, when we see differential loss to follow-up, we'll assume that it's also outcome-dependent. Now, it could be that the loss is related to good outcomes, but typically it will be related to bad ones. Patients who are doing well often are incentivized to keep in the trial. But in either case, we're going to interpret differential loss to follow-up as a threat to the author's conclusions, whatever they are. So differential loss to follow-up should plant some seeds of doubt about the results that the authors are trying to convince us of. So how can this be fixed? Because the bias comes from removing patients from analysis based on their exposure and outcomes, then one thing that we could consider would be to impute the data that we had lost. Meaning to say we can guess at what the data would have been. And if we were able to make very good guesses about what the data would have been, then the bias would be completely eliminated. But for the most part, we're able to make reasonable guesses that will at least reduce the bias. So it's generally a good idea to use imputation strategies whenever you have differential loss to follow-up in a clinical trial. So one specific method of imputing lost data or missing data is called MICE, which stands for Multiple Imputation with Chained Equations. It's a pretty technical procedure, but it involves using regression equations to guess at what the missing data would have been using the data that we do have about each patient. And we use this method multiple times so that we create essentially multiple completed sets of data using various predictions. And then what happens is all of those multiple completed data sets are combined, and the variation in the different predictions is added to the variation in the data itself, and that allows us to produce a reliable inference. Now, imputing multiple data seems pretty suspicious, especially the first time you hear about it, but it's actually a very reliable method to decrease bias that comes from loss to follow-up in a controlled trial. Now, whenever somebody starts a clinical trial, they hope that there will be no differential loss to follow-up. But that trial will only be performed once, and at the end of the trial, investigators are stuck with the data that they have. So if there was differential loss to follow-up, or if there was some concern for selection bias, using mice to impute the missing data is a great idea in order to get rid of some of the bias that the study may have picked up. Now, if the crude result is close to the mice result, then you can conclude that the loss to follow-up really didn't introduce any bias. But if the crude result is different from the mice result, then you can feel good that your imputation has decreased the amount of selection bias in your data. To summarize what we've talked about so far, selection bias occurs when the analysis criteria are linked to both the outcomes and the exposures. So if more patients in one group are lost to follow-up than the other, then that is what links the analysis to exposures. And if the patients with specific outcomes are more likely to be lost to follow-up, then that's the second step, which links the analysis to outcomes, and that will create a bias away from the null hypothesis. Mice is a statistical method that can help decrease this bias in order to allow better statistical inference. So now we'll get to the MINT trial, which was a study to investigate whether using more liberal transfusion goals would improve outcomes in patients with myocardial infarction. Unfortunately, in the MINT trial, there was a pattern of missing outcome data that was concerning to the investigators, so they decided to use mice to decrease the potential for bias. Here's the consort diagram for the trial, and if you look at it, it's maybe clear that there's no obvious differential loss to follow-up. There was a 1.1% loss in the control group, and there was a 2.1% loss in the liberal group. However, if you look a little bit closer at that data, 65% of the losses in the treatment group were withdrawals in the hospital, as compared to only 15% in the control group. And because patients will withdraw early when they believe that the treatment will or is already causing worse outcomes, then this difference between the two groups does create the possibility for selection bias. So what sort of bias could this differential loss of follow-up cause? Now, we're worrying that the patients who withdrew early could have done so because they were having worse outcomes. And if more patients withdrew from the treatment group than the control group early on, then the measure outcomes would be biased to make the treatment look better than it actually was. Now, this type of bias would mainly threaten the outcome of the study if that study was showing a good benefit to liberal transfusion. So we would describe the bias as being a bias away from the null hypothesis. So using the crude data and only analyzing the patients who stayed in the study, The authors found that the relative risk was 1.16, with the 95% confidence interval of 1 to 1.35. Now, after they used mice to impute the missing data, the investigators recalculated those estimates and found a relative risk of 1.15 and a 95% confidence interval of 0.99 to 1.34. Now, the fact that the estimates in both cases were almost identical is really reassuring that the study did not have significant selection bias due to the differential loss to follow-up. So the final analysis of differential loss to follow-up and selection bias in this study is that there is unlikely, even though there was some differences between the loss to follow-up patterns for the two groups, the analysis using multiple imputation didn't really change the final conclusions. Therefore, it suggests that those differential losses were not truly outcome dependent. Whatever other issues the study may have had, it does not seem like the measures of effect that they estimated were significantly biased.